And I'll just let everybody know that Peter Johnson will not be joining us live today, but he does have a recorded presentation that we'll present to you on his behalf. So a little bit about Peter. He's a second-year medical student at one of the research program officers at the AIC. His interests are varied, but right now he's juggling interests in bioethics, digital medicine, and artificial intelligence. In his spare time, you'll find him tossing pancakes and hurling some bad puns. Hopefully, his presentation today in the form of a recording opens some windows to new discussions on digital health and ethics.
Hello, thank you for joining and a virtual welcome. My name is Peter Johnson, and today I'll be presenting on the implications of telemedicine and social health disparity and evaluating to what extent has technology truly brought us closer or created a rift in access to better quality healthcare. Before we get started, I have no disclosures or conflicts of interest to declare. Here's a brief overview of my presentation. Today I will be beginning with a brief refresher to provide the context and background for our current situation, discuss the objective and methods of our study, some of our research findings, followed by a discussion of various themes, limitations, and implications of these findings. The transition to telemedicine, or virtual care, including telephone appointments, online consults, and video conferencing, among other modalities, has brought about several advantages, putting us in touch with advanced remote monitoring, increased patient safety, reduced risk of disease transmission, increased convenience, and, according to many, an increased access, bringing healthcare to our fingertips. At the same time, however, it has its share of disadvantages, including a lack of in-person healthcare and, counterintuitively, created a divide amongst vulnerable populations, pulling the plug on their access to health services. Now, in this study, we aim to characterize these barriers to accessing virtual care amidst the pandemic. In order to do this, we designed a scoping review to search 3 readily available databases, including PubMed, Embase, and Google Scholar, on social barriers to virtual healthcare. The time range was limited from March 1st, 2020, which we defined as the onset of the pandemic, until present. We used North America as a setting restriction and English as a language restriction, and we included some of the following keywords. Now, we identified a total of 18 studies, and the findings of our review drew many parallels to conventional care. Firstly, geographical disparities were still seen in virtual care. In particular, we observed that the geographical proximity to primary care clinics and referring hospitals were important predictors for accessing telemedicine, suggesting that access to care in most rural areas is still persisting in the context of telemedicine. This is counterintuitive and goes against anticipated effects of telemedicine in bridging the gap to access geographically. Now, secondly, we observed a general gap in knowledge on generational disparities. Of the existing evidence, however, we determined the digital literacy of generational gap did not seem to impact access. This suggests the use of a certain telemedicine modality or in-person care has little effect on whether the elderly chooses to make use of a healthcare service. Another major finding in our review concerned income inequality and lower socioeconomic status, which was associated with lower access. In fact, there is a growing body of literature which is focused on the cost of economic status, reporting patients with a lower median household income had decreased access to telehealth compared to middle and high income patients when it comes to accessing telemedicine. Now, social disparities were also demonstrated in a number of studies. Many vulnerable ethnic minorities, particularly the Indigenous, Asian, and non-English speaking demographics, were shown to be less likely to use telehealth services, following a similar trend that persists in much of conventional healthcare. Now, in spite of these findings, this scoping review has a number of limitations. First, the vast majority of studies examined associations and present only low to medium quality evidence, which means more rigorous clinical trials are warranted to validate this evidence. Second, there are vast differences in the methods employed and study design for each individual study. Third, there are inherent differences in both the type of telemedicine modality and the extent of use within centers. For example, some centers use 50-50 telephone and in-person visits, while other facilities use video conferencing 100% of the time. Now, finally, there are also variations in reported outcome measures, such as the time engaged with the patient, the quality of the interaction, and response or lack of response to follow-up. Ultimately, these findings are suggestive of risk factors and associations in predicting access, which are divisively scattered and very complex. We believe this may be due to the inherent systemic flaws in our healthcare and telemedicine, which we have not yet been able to overcome. As virtual care is a new norm and it's here to stay, future avenues should focus on characterizing these systemic flaws. So what exactly are they? As well as collaborative efforts of care providers, policymakers, and innovators to create solutions that focus on both the community and patient engagement to close the bridge between divisions created by both systemic and technological barriers. Thank you for listening, and this work wouldn't have been possible without all of the help we received from our supporters and collaborating organizations.